welcome everyone. I'm Sharon Iloranta. I am the Medical Director for Quality and Safety Initiatives here at Qualis Health. I am happy to be hosting this kickoff webinar for our County Action Network group, our CDI Action Network group today. I'm substituting for Tina Schween, who is at a conference in Baltimore. A couple little housekeeping details. We do have everyone's phone on mute until the end of the presentation, and then we'll open the lines up for discussion. But you can feel free to type questions into the chat during the call, and we can either address those along the way or we can revisit that at the end. Just a little overview about how today's CDI Action Network conversation is going to go. I have just a little bit of overview material for you in case you need a reminder of where we are with this. We will hear from our featured hospital on our first antimicrobial stewardship field trip of this four-part series. We are very happy to have some distinguished faculty members of the Antimicrobial Stewardship Committee of Seattle to be on the line to offer a panel reaction to the field trip that we're going to have. We will have time for discussion and then offers and requests and a little bit of homework at the very end. Whoops. And I'll have homework of learning how to push the button. Okay, as many of you are participating with us in more than one of our healthcare-associated infection action networks, just a little reminder, we're operating action networks that will work on reducing catheter-associated urinary tract infections, reducing infections with Clostridium difficile, and reducing surgical site infection. This particular presentation is in support of the CDI Learning and Action Network. I did it again, didn't I? Great. I got it. So with regard to CDI, our goal is to reduce hospital onset CDI, and this is done through two major components, and that is to decrease susceptibility to these infections, and that is mostly through the implementation of an antimicrobial stewardship program at your facility. And as we'll learn through these four virtual field trips and the conversations that follow, that one size doesn't fit all, and that there are many approaches to this that may be applicable, and we'll certainly learn about innovative approaches. And the other main focus of this program will be to decrease exposure of patients to CDI, and that at this point is mainly through, of course, hand hygiene and environmental cleaning. And we know that some of you are already quite advanced in terms of the antimicrobial stewardship programs you may have, but maybe working a little harder on the hand hygiene and environmental cleaning. Some are experts in both, but our goal is really to meet everyone where they are with the types of educational and assistance and technical assistance to help you to meet the goal of the Action Network. In this year, what our goals will be, the Qualis Health team through this Action Network, is to have everyone be reporting their CDI baseline data into the CDC's NHSN program. We'll be communicating with you about conferring rights and all of that fun stuff, so you stay tuned for that. And during the year after we get the baseline data entered, we'll be sharing these practical approaches to antimicrobial stewardship in the four-part webinar series. And once we do have the baseline data established by next year's program, we will be able to understand where everyone stands and provide some more deep dive technical assistance to facilities that have baseline rates greater than 6 cases per 10,000 patient days. And we'll be able to add some more webinar or other types of technical assistance to the information around hand hygiene and environmental cleaning to also decrease exposure. One of those approaches that I think may be particularly fun and innovative to do would be to explore some cross-continuum type of approaches to that, bringing in long-term care and other community partners. Because as with many of the other multi-drug resistant organisms that we have in our communities, they really are community-based, and a community-based approach can really be helpful. We're really excited for what's going to happen in both 2012 and 2013. So a little visual of what we're going to be doing with this four-part series. Today's field trip is to Swedish Medical Center. The next one will be Yakima Valley Memorial Hospital, Harborview Medical Center in March, and St. Mary, which is in Walla Walla, in April. So it's a quick bunch of trips. And the purpose of all this is really to create the opportunity for these various facilities to share their implementation stories, but for you on the phone and online to ask questions of the presenters, to interact with the reactor panels that we will have, kind of figure out what you've heard that might work in your own area that you might try testing, or you may have tested something they talked about that didn't necessarily work well and want to have those conversations, try and get the silos to connect across our state. A little intro to the field trip we're going to take today. We all know that the primary goal of antimicrobial stewardship is to arrive at the optimal selection, dose, and duration of an antimicrobial that results in the best clinical outcome for the treatment of infection with minimal toxicity to the patient and minimal impact on subsequent development of resistance. Really what we're trying to do is kind of accomplish our three-part aim. We're going to have better care for individual patients, better population health, and reduction of costs to the system. We all know that the nature of the problem here is that inappropriate remains to be defined for us, but we'll probably hear more about that. Antimicrobial use can lead to the development of antimicrobial resistance on the part of certain organisms, increased mortality, morbidity, and then increased expenditures. I did want to pull out the increased mortality and morbidity piece because I think any of us who have had a C. diff infection, and I haven't personally, but we do have coworkers in our company that have, or have, taken care of a person that has had one of these, understands that it is a very unpleasant experience, and that older, frailer people with more comorbid conditions can really experience bad outcomes with C. diff, and patients do suffer from this, and we want to make sure that we can avoid C. diff wherever we can. I want to remind everybody on the phone that at the end of last year, Qualis Health sent out a self-assessment form for you all to fill in, just trying to figure out kind of baseline of where all of our participants in this action network are in their AMS work. And here's just a peek at some of the results. 60% of you said that you do have an antimicrobial stewardship program, and of those that responded that they did, nearly all do some of the things that are listed here. They monitor prescription appropriateness after the first dose, may use some lab parameters to automatically adjust doses. They use at least 5 to 7 supplemental strategies from IDSA SHE. A number of you address the impact of your program, so try to evaluate how well it's doing by looking at the percentage of the organisms that you're seeing that are actually sensitive to the antimicrobials you're using, and then taking a look, for example, at another outcome measure, which might be expenditures. Barriers were cited by a number of the folks that responded to this assessment, talking about it costs money to have an antimicrobial stewardship program, and it's not necessarily a revenue center. And there is a shortage of personnel that are qualified and available to pass these programs. So we'll be really interested in hearing as we go through the field trips about how some of our facilities have focused on kind of breaking down these various barriers. Really happy today to have as our main presenters from Swedish Medical Center, Dr. John Hauk, who is the Medical Director for Infection Control and Antimicrobial Stewardship, and John Barrett, Pharmacist, Director of System-Wide Clinical Pharmacy with Swedish. We have on our reactor panel 2 members from the Antimicrobial Stewardship Committee of Seattle, John Lynch, who is with the Infectious Diseases Clinic and a variety of other positions at Harborview Medical Center, and Dr. Michael Mitt, Infectious Disease, Infection Prevention Employee Health with Virginia Mason. I hope you'll all take advantage of their presence on this presentation and ask them questions. We are now going to get into the bus and travel to Swedish Medical Center in Seattle for our first field trip.
Hi, this is John Hauk at Swedish Medical Center, and I'm with John Barrett, who's our Director of Clinical Pharmacy. So we were pleased to be invited to present what we've been working on at the Swedish Medical Center over the past year. Can everybody hear me okay there?
Sounds good to us, thank you.
Okay. I'm having a little trouble advancing this. Let me. Okay, good. So I think It's exciting to be able to present what we've been working on in Swedish because it's been a really busy 2 years as we've been designing and implementing a AMS program. And I feel like we're very fortunate to have a system here, the administration leadership at our hospital, which really does value stewardship and has been willing to really invest a lot and see the importance of these efforts. So we feel lucky that we haven't faced a lot of barriers towards getting it going and having what we think so far is a successful start to our program. I think initially when I go talk on this topic to our hospital and staff, we spend a lot of time talking about the background, why stewardship is so important and why we really do see antibiotics as a treasured resource that we really need to take good care of. I think I'm going to assume that the audience here kind of already starts with that as a background and really kind of jump into more about how we went about designing our program, a little bit about the considerations in terms of planning to start up and get it going, a little bit about how it works, and some on the sort of data we're getting back, how we evaluating the impact of the program, and then finally to touch on a little bit about ideas of where we're going next. And so it is sort of a work in progress, and we feel like we just gotten started and made good progress, but I think we obviously are really looking forward to a lot more to go. So in terms of what Swedish hospital system is like, we have 4 hospital campuses currently, Issaquah and Ballard and Birchville campus and Cherry Hill campus in downtown Seattle area. And we have about 1,200 total patient beds. And we do have a residency program, including surgical and family practice residencies, which are fairly active. We have 7 full-time ID doctors who on the campuses as well. So what we've done in the past, part of our new part of the program, is sort of a traditional approach to antimicrobial stewardship where we had restricted formulary, and that's worked very well for us to have certain drugs which are only available to ID docs to prescribe. And we feel that really being cautious about utilization of these special drugs has been paid off a lot over the long run in terms of saving them to the patients who need them the most. And so I think that's been continued as part of our program as an important backbone to it. I think the other thing that's been in place for a while but actually has gotten more exciting with the way we're working on our program now is using care pathways. So order sets for pneumonia, urinary tract infections, sepsis, skin soft tissue infections. So these are ways to kind of drive the use of antibiotics from the very beginning, from the entry of the patient into the system when they're being admitted. And then finally, traditionally education, going to get talks to the residents and other groups has been an important part of what we've done in the past, although we kind of sometimes feel like it has limited impact in terms of the duration of the educational effect. So what we've been getting ready to implement the new phase of our program we started planning back in 2008. And that was started with a plan to buy some decision support software, and we went through an evaluation process looking at different products out there. And this involved a business plan that we submitted to administration, which included a lot of work for both pharmacy and infection prevention department, as they're both key stakeholders in the use of the software. We decided ultimately to go with the Paradox software program, and through 2009, 2010, went through the installation process of it and trying to get it to interact with Epic or Lab database and other sort of some of the other databases we had at the hospital. And then in early 2010, we went through a whole plan of what the prospective audit and intervention team would look like, who would be on it, how we would monitor it, and how we would sort of roll it out to the hospital. And then our go-live date for this was September 2010. So right now we're about a year and a half into the program of the newer phase of having a prospective audit in place. So I want to go through sort of some of the things we thought about in putting a program together, because I know some places are still in the earlier phases in terms of how they're going to get started on this. So one key thing was getting administrative support. And obviously to remove the barriers, you need to have administration behind you for the financial support, and also support in helping with the medical staff and other key stakeholders to emphasize the importance of the program. So we put in together a business plan that supports the program we thought was very important to help offset the cost of personnel, time, and software investment. So part of that is looking at what the estimated cost savings might be in terms of what the hospital spent annually on antimicrobials and what we could expect to save in terms of cost reduction. we also made arguments that there would be a lot of effect on quality measures and compliance with regulatory compliance with that revolve around antibiotic use. And I think that's been borne out over the past year and a half as we look at going through a number of JCO and other certification for a new hospital, where we found that having the program in place really has made it easier to address the concerns of inspectors, and also looking at some of our compliance with scope measures as well, scope measures, and to help make sure we're meeting national guidelines there. And then finally, another selling point for administration is sort of looking at the bigger picture of how we reduce costs, not just the hard cost of antimicrobials, but looking at length of stay and readmission rates. We haven't been able yet to work on getting that data and presenting it in a way to see if we can improve the benefits, but I think inherently we think that there should be some positive impact, and that the cost we would save there would be much greater than the cost of the antimicrobials. So I think trying to work out the hard cost is probably the best, because it's something that's more deliverable and you can more show your benefits. For infection control, it's important to partner with them closely, because the decision support software we use for stewardship was also going to be used for surveillance, and our business plan to support building this also affected both departments. And then when we thought about how we can evaluate the impact of our program, we need to think from the beginning, even before it started, about what measures, indirect measures we'll have, like multi-drug organisms, what the prevalence of those are, our VRE, our MRSA and C. diff rates, as well as some of the infection rates in the hospital that are monitored by the epidemiology department. So kind of working hand in hand with them is really important from the very beginning. And then we also had to think about how are we going to get the docs to buy into the program and accept it. So what we really want to do from the beginning was, as we planned it, get the key stakeholders involved, such as the hospitalist and the critical care department and some of the surgeons involved backing the program. We also spent a lot of time going out to educate the different departments before the implementation, so it wouldn't come as a surprise and people would be anticipating it, giving grand rounds on the topic and reaching out to some of the leadership meetings about the program. We also really, in starting to get people ready for the program, really focusing on patient safety and quality and looking how it's going to be a benefit for individual patients as well as the overall hospital environment of care and safety, and really putting the focus as it's not just focused on reducing antibiotic use, but really how it really translates into better outcomes for their patients. And then, again, looking at how will the recommendations of the team be communicated to the doctors is really essential. So we thought a lot about how we would end up putting a note in the chart versus a non-permanent note, and how we would document and communicate our recommendations in a way that would work best for them and be best accepted. And part of that is really stressing the voluntary nature of any recommendations that we make, so that people realize that as the doctors for the individual patients, they'll always know best about what's right for the patient, have the best perspective as they're doing the hands-on care. So I think stressing these points was kind of key in the build-up to implementation. The other big political concern, or concern from in terms of acceptance, was making sure that the infectious disease doctors are behind the program. I think traditionally there's been concern that an AMS program where they're actually giving advice on individual patients may replace the need for ID consults and be a threat to the business model of ID, or a threat to getting the expertise of ID involved in patient care. So we had to address that. There's also concern that if we're interfering and making recommendations on patients followed by ID doctors, that could be disruptive and a threat that would decrease the acceptance of the ID doctors in the program and their support, which would then kind of downstream from that affect the other clinicians. We also are facing a barrier that stewardship hasn't always been traditional priority for ID docs. So often we think about the individual patient, what drugs are kind of the newest drugs, and most making sure we bring in the big guns to fight potentially severe infections and not miss anything. And so I think trying to look at it from a lens of stewardship has not always been what we're best at. And I think that's changed a lot for our organization over the past few years. I can say that for myself as an ID practitioner as well, it's really changed the way I think about the use of antibiotics, and start to see the downstream side effects and adverse effects of using more than we really need to. And so I think trying to build that into the ID docs practices was something important. The other thing things that we wanted to do to ensure ID backup for the program is that getting them involved in the planning and evaluation from the beginning. So making sure everyone had some stake in it and some say in how the program worked. We also want to make sure that for the time they spent, coming to meetings and giving feedback for our program, that they got compensated for their time and also compensated in terms of getting CME credit for the meetings they attended where we were discussing clinical practice. And also I think another key part was to emphasize that most programs around the country have implemented prospective audit and intervention programs that found actually a positive impact on the number of ID consults. Often it becomes apparent that some patients will need or benefit from ID involvement earlier in their care or sooner, or maybe get a consult where they wouldn't have necessarily when they really needed to. So I think that the net impact is probably one of promoting the use of ID docs in more complex cases. And I think that's probably helped the acceptance for ID docs, as they noted that, as they've all sort of seen that downstream effect. And I think also trying to be careful with our team, how they work, and to be sensitive to not, giving recommendations that might conflict with how the ID doctors are managing the patients, because they're the ones who really see the patient directly and have the best insight. So how do we structure our program at Swedish? So the overarching supervision comes from what we call the Antimicrobial Stewardship Oversight Committee. So this is a multidisciplinary committee, which I'll describe in more detail, which actually has a lot of direction for all the different activities that we talked about. Formulary approvals and the restrictions are reviewed by this committee. Also the care pathways and protocols, such as pneumonia care pathway or skin soft tissue care pathway, those are reviewed and actually changes are implemented under the leadership of the committee. And then finally, the day-to-day workings of the antimicrobial stewardship team are answerable to the oversight committee in terms of how are we doing, what's the impact, what is the feedback we're getting, are the types of things we're doing appropriate. So the committee has really been great in that it gives us one body that oversees a lot of the different activities related to antibiotic use in the hospital. So on the team meets every month. We have a 2-hour meeting monthly, and there's all the ID docs are part of the team, and generally we should have at least 6 out of 7 attending most meetings. Infection control and epidemiology is important stakeholders are there. Pharmacy, obviously, and microbiology. There's usually 1 or 2 people from the microbiology department to help look at how we're doing testing, how do we report sensitivities, what are we seeing in terms of trends of sensitivities, and what more information do we need from the microlab to help support the stewardship efforts. And then finally, the hospitals and critical care members have been good stakeholders, especially early on when we were getting plans to implement the program, but we have them often come in to discuss certain parts of the protocols or for example, we had to talk about an update on sepsis recently from the critical care team. So as we mentioned, additional roles for the oversight steering committee include sort of looking at evidence-based guidelines, how do we translate those into practice in Swedish, reviewing what we're getting in terms of data of the effectiveness of the interventions and what sort of impact we've seen. I think it's a little bit redundant, but just talking about how reviewing the policies and protocols in all ways that antimicrobial use is going on in the hospital, order sets, dosing and monitoring policies for antibiotics and formulary decisions. So the other key part of building the program was looking at how we were going to use technology. So we already had an electronic health record with order entry. Epic is what we use. That's been powerful because it allows us to look at all patients at multiple campuses from one room, review their radiology, microreports, and clinical data notes. And then we also have implemented the Theradoc decision support software, which we use that to identify patients to look at and how to track changes, to track sort of interventions over time. And we also have some software that we use within the pharmacy that comes from McKesson, which allows us to review antimicrobial use in terms of the actual amount of antibiotics used by DRG, to review some of the cost data and to look at these trends over time, just kind of data mining the pharmacy database to what we're seeing in terms of the impact. And that's been very helpful because doing that work by hand or without that would be really impossible and would be too limiting. So the real heart of what our new program is the prospective audit with intervention feedback, where we review individual patients in real time, and we then give feedback to clinicians with a recommendation for a voluntary change in how they're using antibiotics, and then we follow up to see whether they accept the recommendation or if something has changed with the patient where we need to modify what we're telling them. So I'll describe a little bit about how this works for us. So the AMS team of Swedish, their core team meets every day, Monday through Friday, and then there's a pharmacy on the weekend, pharmacist on the weekends, and on ID doc who's scheduled to meet. But there's a 2-hour meeting with the ID doc and the pharmacist daily, and there are 3 different ID docs for the core team who rotate, and we try to limit it to a small number of infectious docs so they would build up expertise, and ones who share sort of the same philosophy and appreciate the importance of stewardship. There's also 7 pharmacists who rotate through, which may be different from other hospitals where they maybe have several members rather than a bigger group. But we found, although it is harder to maybe have as much consistency when you have a bigger group, we found a real downstream benefit of educating a lot more pharmacists who then went out when they're doing other things to other departments and then educate other pharmacists, and we're doing the stewardship work on the patients they're following on a regular basis. So we think that's actually been very helpful in terms of education and have a lot of different pharmacists involved. And then we sit in a room after the pharmacist is there for 8 hours a day, and they review information earlier in the day, and then we have a middle-of-the-day meeting, and then we look through the EPIC documentation, the microbiology, radiology, pharmacy data, and then come up with interventions when we think it's appropriate. So we use alerts from Paradoc to identify the patients we want to look at. So these, a whole range of different types of alerts. These could be either significant positive cultures who are not receiving appropriate treatments, like a patient has a positive blood culture and haven't been started on therapy yet, or say there's a patient who's on a lot of antibiotics but has all their cultures in negative, then a Paradoc alert will go for that as a patient to look at. Polymicrobials, patients are on 2 or 3 more classes of different drugs, would be obviously a target for looking at for the team. And then there's certain drugs which we think are so important that any patient on those probably should be examined by the team to make sure the use is appropriate. And then there are certain organisms that likewise, ESBL or MDR organisms that we should really take a look at that patient. There's a whole variety of other alerts that we use, but these are some of the core ones that form the basis for a lot of our interventions. Often we may look at a patient for one alert, and we end up making an intervention for a totally different reason. So the alert may bring up a patient who we think there's like a mismatch between their drug mismatch. We really find out that there's some other issue going on with them that we need to have a different type of intervention for. So what are the type of interventions we do? I won't go into too much detail about these. These are sort of some of the core things that we do on a regular basis. So obviously, drug mismatches are a big one and a big safety issue. So patients who have an organism that's not covered by their current therapy. Streamlining or de-escalation of therapy is an important one in terms of the impact on reducing the amount of antibiotics used. So patients are on multiple antibiotics in a culture data bank. We can now narrow down to one therapy, or limiting redundant coverage that doesn't have any additive benefit for the patient. Dose optimization, we're probably getting into more and more where we see issues with NACO dosing or novel strategies towards dosing different antibiotics that the team can get involved with. PO, IV, I said it should be an IV to PO conversion we've used for a while, and really that actually pushed more to the floor pharmacists rather than the team, but occasionally we do have that as part of our recommendation. And then length therapy is a big one, as that a lot of patients are placed on antibiotics for things like community-acquired pneumonia or hospital-acquired pneumonia or UTI, and then no one really comes back to readdress whether their therapy can be stopped. And I think this is probably where we have some of the biggest impact. And I think also from an educational standpoint, making sure that people are following IDSA guidelines for length of therapy. A lot of people aren't aware of how a lot of those have been shortened midway of the shorter course. So that's how we've seen a real cultural change in how we use antibiotics in the institution overall, in terms of people becoming more cognizant of how you can use less therapy and with the same outcomes. And then finally, there's a whole group of patients who, when we see them, we know immediately that they're going to need to be seen by ID at some point in their stay, and we have the ability to recommend getting ID involved. Typical examples of that would be Staph aureus bacteremia. We know the patient has to go out on IV antibiotics will need at least 2 weeks of therapy and needs to be evaluated for more severe infection. Or there's certain organisms like ESBL, E. coli, where we know getting ID involved will be helpful to getting the patient on the right treatment, getting them discharged sooner, and making sure the care is appropriate. And that's also, comprises a significant part of what we do. So I want to give an example of a patient that will maybe run through a little bit about how our interventions work and how we document them and give you a better idea of on a per case basis what we do. So this patient was a 74-year-old male who had a history of prior urosepsis and bacteremia. Several months before this current admission, he had come in previously with ESBL E. coli in his blood from a urosepsis, which was sensitive only to imipenem. And he was readmitted with new fevers, urinary tract infection, bringing a rod through the ED to the hospitalist team. Alert fired off on him because he was started on Zosyn and levofloxacin. So on day one of the hospitalization, we get an alert, and the team reviews his case and quickly looks back. That should be Serodoc alert fired for polymicrobial virus. The team looks at the patient, quickly realizes that he very recently had resistant organisms, which may not be covered by his current antibiotics. So we make a call to the MD to recommend changing to imipenem and getting an ID consult, since again, we know the patient likely will benefit from that kind of expertise. So in this case, the patient's therapy has changed, and later on he did prove to have a highly resistant organism. And so we thought this is an example of where getting involved early is kind of a near miss, where the patient gets on appropriate therapy early on and more quick. There's a day or two sooner while he's on appropriate treatment. So how do we document this in the note? So we decided in formulating our program to always put a permanent chart note in the EPIC medical record. The feeling there was that by putting a permanent note there, it really gives backup to the primary team that we did make this recommendation is coming from us, and we backed it up with a permanent chart note so that they feel like if they change something on the basis of what we're telling them, that's documented in the permanent records. And I think that's been the right decision. We haven't had any major complaints about that being part of the way things work. I think people actually appreciate it and sometimes ask if we put a note in there for us. If they don't know we're automatically going to do that. What we'll say is the AMS team reviewed this patient and we give a little scenario of what's going on. In this case, they're receiving antimicrobial therapy with Zosyn and levofloxacin, and they have a history of resistant organisms. And then the key underlying part is our actual recommendation. Please consider changing antimicrobial coverage to imipenem to cover the possibility of an ESBL organism. If else be indicated, consider ID consultation. For example, we say Dr. So-and-so saw this patient last admission, so you could call him, and that facilitates the right doctor getting involved in the loop right away and makes it easier for them. We then have sort of the caveats that every note has, which this has been a recommendation formulated from chart review from microvasc, radiology, and all the data we have, but it's not a substitute for the clinical judgment of a provider who's directly involved in the patient's care or for an ID consult. We also make a point that the recommendations reviewed with actually an ID doc who's on the program to actually give more weight to it, hopefully. Often the recommendations of pharmacists are very good at doing what we need to do, and they often don't change much, but we think it's important to have it reviewed to kind of help, again, build the credibility for the program for the clinicians. And then finally, we recommend contacting the AMS team with any questions. And we have a number that we're always at, and people can reach us. And often we'll have teams now start to call us and say, hey, could you take a look at my patient? We have a question about the antibiotics, and you can take a look and leave us some recommendations. So for the next bit of time, I'd like to sort of review the impact of our program, how we think it's been doing. We've kind of looked at some of these measures here, but haven't really worked through all of them. Some of those are looking at the acceptance rate of interventions, what has been the impact on antibiotic use in our medical centers, sort of comparing in the pre-implementation era before September 2010, and then how we've done since that time. Eventually, we like to look at other measures such as adverse drug events, the rate of MBROs in our hospital, length of stay, and readmission rates, and then guideline compliance. But those will probably take longer to get to those since we're hopefully do that soon. When we look at all the alert types, this gives us an example of which Serodoc alerts fire and which ones are triggering on the review of the patient. Most of these come off of some positive culture or some use of certain antimicrobials. When we look at this slide shows the number of interventions we make. So overall, for the first year of the program, we did about 4,300 patients reviewed. Of these, we made about a total about I think the total number of who actually left notes would be probably around 1,000 or so. And it worked out to about 20 interventions per week, about 4 or 5 per day on average, where we actually leave a note, call the team, let them know what our recommendation is. And this just gives you kind of an idea of the different types of interventions that we make. The bigger ones are streamlining de-escalation or shortening duration of therapy or recommending an antibiotic based on positive culture. So what you can see is the thing we're most pleased about of all our recommendations, we have about a 90% acceptance rate. And this has been very consistent throughout the program. It started out pretty high, and we maintained that high rate over the past year and a half. So I think that we feel like that's a pretty good target. But when we look at antibiotic costs, what we see is comparing, you can see at September 10th is where the program started. There's big variation from month to month in what we see with utilization. And you can see things go up and down. So what we really try to do is average out the year before the program and then the time interval since. What we've seen is on average at about $60,000 of savings per month for the hospital system, comparing the post-implementation to the pre-implementation interval. And this is kind of continuing over time. We're hoping, obviously, that'll continue to drive down as we get better and smarter about our strategies. When you look at the antibiotic cost per patient day, we've seen about a $5 per patient day decrease for the system over the first, year and 3 months of the program. And again, you can see sort of the pre and post implementation and the big fluctuations that we see that make it challenging to kind of even that out and get but I think over time we've seen a consistent drop. When we look at by drugs, we can see that these are some of our targeted drugs that we tend to go after. So Zosyn, we've seen a 20% decrease. Levaquin, about a 17% decrease. IMI's decreased some. Cefavine's actually gone up, which is actually part of our preferred strategy, trying to avoid some of the broader coverage of Zosyn that we don't necessarily need for gram-negative organisms. And then we've seen a drop in Vanco use, and then even a drop in Dapto, which was on a market skyrocketing during the time period that we started the program. So just leveling that off would have been great, and to see it go down a little bit has been really good. So what is our experience at the first year? Well, we've had a high acceptance rate of our interventions. We've had really great feedback from clinicians, very few negative calls or people not happy with the program, and a lot of really appreciative remarks. We've seen a lot of near misses averted, like patients who have a serious infection like the fungemia or bacteremia who are not on appropriate therapy, where we've caught. We've also seen that pharmacy expertise growing, with pharmacists are getting more and more comfortable with doing interventions when they go to work in other areas. They carry that out and educate other people. So there's been sort of a ripple effect. We've also seen other people calling to get our team to look at their patients, not just finding the patients to intervene on, but actually getting referrals. And we've also seen a huge impact in how doctors use charting to indicate how they're using antibiotics, why they picked what they did, and how long they're going to treat. So that's been a big change to see that people know it's important here. There's a stress on it, and they actually are getting, they're kind of inspecting their own use of antibiotics more closely. And again, I think education is much more effective when you do it in the context of individual patients. So next steps, just briefly, we'd like to work on instituting procalcitonin assays. We have this going to start running in the house this month, and then we're going to start to find out how we'll use that as a way to kind of differentiate between bacterial non-infectious syndromes, for example, for COPD or respiratory illness. Also use it to limit therapy in terms of duration when people have normalization of procalcitonin for certain syndromes such as pneumonia. And we're working on building a multidisciplinary team with the ED, with the hospital, and critical care, with how we'll order these tests, order procalcitonin, how we'll use it, and how we'll fit it into our algorithm. So we're excited about that project this year. Also, we're now implementing the extended infusion of piperacillin tazobactam in the ICUs, sort of a strategy to have more effective use of the drug with hopefully better outcomes for severe infections, but also actually use less of the drug itself. And I know a number of hospitals in the area here have been successful with that, so we're excited about that. We'd also like to really increase the number of patients we capture with our interventions. So doing a better job of increasing the number of interventions we do to get a better percentage out of reduction. and looking for these other endpoints that can show the impact of our program. We probably had a big first year in reducing utilization, but each year it'll get harder and harder as you sort of squeeze the juice out of the orange. You're going to have less and less in terms of improvements you can show. So one thing we'll be looking at other measures that we can demonstrate to administration that we've not only are we kind of paying for the program as I think we've demonstrated with our current numbers, but what's the bigger effect in terms of patient safety and the financials for the hospital. And then finally, I just want to end up, in terms of saying something specifically about C. diff infection. At the very same time we started our program, we also went to a PCR-based testing for C. diff, which we may have picked up 20% more cases with that type of technology. So as we, it may be hard for us to see a change in C. diff rates as we implemented that, but we'd like to ultimately see if we can kind of continue to drive C. diff rates down, although there's multiple factors, as was mentioned before, that impact on that. We're not sure what the effect on antibiotic use we've achieved will be enough to drive them down. What other measures, do we need to focus on for a hospital are big questions that will hopefully we can be part of our discussion here as the year goes on. And then for AMS specifically, do we need to look at targeting specific drug classes like quinolone? We see a huge association between the patients who get C. diff and then quinolone use, and how can we be better about that as a way to reduce C. diff, or even other drugs like proton pumps. So in any case, I'd like to thank all the folks who've been, especially John, who's been instrumental in implementing our program, and great to work with, and all the other great team members who've really been passionate about this. And thank you for calling for letting me present our program. So I guess with that, I'll open it up to any questions or any comments.
Ladies and gentlemen, the lines will now be unmuted for open discussion. I'm going to unmute the lines, but you can use *6 to remute or unmute your line.
Yeah, keep updated on
the lines are now open.
Hi, Alicia?
I do.
Yes. Operator, actually, this is Sharon, and we would like to hear, before we have questions, could we hear from our reactor panel?
Oh, I'm sorry. Go ahead.
It's okay. No problem. We've got our folks on the line here, Dr. Lynch and Smith, and I wondered if you wanted to comment a little bit about what you heard on this field trip to Swedish, any reactions you have based on your own experience, and any pearls you'd like to share with the audience.
Sure. This is John Lynch. Mike, is it all right if I comment?
Absolutely.
This is John Lynch over at Harborview Medical Center, and, I've spoken to John about this. We're actually working here in Seattle on a consortium combining sort of all of our antimicrobial stewardship programs to sort of exchange information. So I've been fortunate to hear some of John's presentation before. And as I mentioned to our group and to others, that I think the Swedish program is really setting itself up as sort of a gold standard of how to practice antimicrobial stewardship. So I have to give John and his whole crew over there a lot of credit for how they're doing things. It is also, it's a great demonstration of how antimicrobial stewardship can be practiced in, a large, complex institution that has a number of campuses, a lot of patients with a variety of illnesses, but as part of that also can draw from a diversity of expertise. You can see from the acknowledgement slide that John put up that he has folks from infection control, microbiology, pharmacy, hospitalist team, as well as other ID docs. And it'd be, definitely worth hearing from folks in the audience who are coming from, different institutions with maybe less diverse expertise, and also places that, I guess one question I have for John is whether this was something that was driven by your teams or the infectious disease docs interested in microbial stewardship, or was it sort of a pharmacy-driven process or an administrative-driven process? I see from one of our questions on the slides on the website that may at least start off part of the conversation.
Well, this is Mike Mintz from Virginia Mason, and again, I just want to thank John Powell for presenting this. We do have a collaborative here in Seattle, as John Lynch mentioned, and that's been very invaluable for sharing information. And we're also very interested in continuing to share information. And we were approached by Qualis, and John's giving the first, or John Powell's giving the first talk, and John Lynch will give a talk down the line about what's going on at Harborview. I just want to mention quickly that the Swedish program is a very involved program with a lot of informatics support. You heard mention Epic as well as Theradoc. I will say, though, that the methodology that Swedish used in implementing this, and I really credit John Pauk and John Zarek there for really leading this effort forward, but that the methodology can be done anywhere, just getting the awareness up. And I think that those parts of what they built there is really the key issue. So I just want to make sure that we sort of de-emphasize the technology parts of things, as I think that many patients may not be at that same level, ours included, from a technological standpoint. But the methodology is just solid about showing how selling the value of this, and I think that it's the right environment at this time. And I do have one question that I will reflect on Dr. Pauk, which is, do you find that the type of issues that the antimicrobial stewardship are seeing now, a year into it, are different? And more so from the standpoint of, do you feel that it's in and of itself is educating clinicians and prescribers of antibiotics to make different decisions, which would, of course, change the kind of interventions that you would have down the line?
Yeah, well, thanks for your kind words about the program. I think that in terms of what John had asked about, I think it was really a collaborative approach from, infection control, epidemiology, and pharmacy, and I think we were lucky to have a lot of people coming around this issue from the beginning, and even you, Mike, from you were here at Swedish at the inception of this, so I think that we were lucky just to have a lot of people on the same page at the same time, and an administration that was willing to see the value of it. So I think it really came from multiple directions and at the right time. So we're really fortunate. Like I said, that success has been depend on backing of the hospital. I think I do see a change over the years we've been practicing where we're seeing automatically that clinicians are adjusting what they do, how they use the antibiotics, and they're documenting, well, we'll stop at day 8 for IDSA guidelines in terms of length of therapy. So we are seeing more that there's a little bit, we're having to look at different areas to kind of find what our interventions will be. So the educational impact has been really noticeable. And so I think that really encouraging the use by having people call us to get us to look at patients would be one thing that may be a little different rather than seeking them out. The other thing I think is with the procalcitonin, that hopefully will be really beneficial to get the hospitals even more involved, critical care more involved with how they use that tool and identifying patients who may benefit from the stewardship team working with them on individually. So I think that's sort of, I think they will change a lot over the next year as we sort of establish a new baseline for the use of antibiotics and how people prescribe things. I think what we the actual impact is only the tip of the iceberg. I think it's really the ripples of it beyond with how people change your behavior is probably more important than the individual patients that we intervene on.
Hey, John, this is John Lynch again. I have another quick question. You sort of started your talk off with the baseline being a formulary restriction program prior to sort of the implementation of your prospective audit and feedback. Is that something that you would recommend as sort of a first step?
I definitely would think that we've been very happy with having a restricted formulary and still very successful and avoided a lot of pitfalls. One is we've seen more conservative use of antibiotics and more conservative implementation of new drugs. I think often there's this bandwagon effect where everyone gets hit by marketing, jumps onto a new drug before there's a lot of clinical data, and I think we've seen over and over again, maybe with tigecycline and more recently with some other Doropenem, for example, the pneumonia study that came out recently, that really it's not always maybe best to be at the cutting edge of things, but to wait till there's more clinical data or really save those drugs for somebody who really knows more of the data behind their use. So we found it very valuable. I would really say that that's been hugely important what we do, and it still is, even though we have a more prospective audit system, I think we still rely on that a lot.
Do we want to open up for questions? Or?
A question. This is Lisa Basie from Virginia Mason.
Yeah.
Hello, I would like to know more information about what is your leadership support, the organization, how do they support your antimicrobial efforts, And also, could you give a bit more information about your AMS oversight program and how the different subcommittees, such as the formulary approval restriction, AMS team, and the care pathways, you mentioned that they meet for 2 hours every month, but how do they actually, what's involved with their work, what kind of IT support do they have, how does all this information collate and be put together and implemented?
Sure. I'll let John Varick answer this because maybe more from administration standpoint.
Right. Thank you. One of the things that happens is pharmacy gets a lot of information from various areas, and specifically with I can take an example of order sets. They are something that have been in place in various care pathways, and we Dawn has a responsibility bringing it to the court team and saying, isn't it appropriate that we review it, make sure that it's totally evidence-based and it's updated on a continuous basis, and then implemented into our electronic medical record. And there is an example of how that whole process intertwines with input from our various experts, and then having the actual implementation. Part of your question also had to do with support from leadership. We have had excellent support from our previous chief of staff, who is now has become our vice president of medical affairs on one of the campuses, but was a champion for us going out when Dr. Pauk would talking at one of the grand rounds, seeing the benefits, seeing what we were going to be doing, and promulgated that message and supported the work that we were doing in various committees that the chief of staff was involved in. We were also fortunate enough that even our CEO was supportive in, when you get feedback from a CEO that says, I know we're doing this, it's the right thing to do, and, to me that is, even though it's not a lot of words, it sure is a supportive of keep it going. Another thing with respect to maybe the financial aspects of it, we always wanted to make sure that we were at least breaking even with what we were doing. And as Dr. Pauk said, we were all about patient care and patient safety, but we are seeing the benefits of reduced utilization, and that has tells a story to our leaders, because then they see that the pharmacy and the infectious disease physicians are helping to keep the organization in the right financial perspective, and which is reducing costs and preventing adverse events.
Thank you.
Everyone, this is Sharon, and I really have appreciated this wonderful discussion that's going on, but I also want to respect everyone's time and be able to finish on time. So what we would like to suggest from the Qualis Health end is that you email us, Tina at qualishealth.org. If you have additional questions you'd like to follow up, we can make sure that we get together with the panelists and have those answers for you. I'm going to skip right over offers and requests, although if any of you have offers, I think requests are the types of questions. Are you looking for tools? Are you looking for what would be an appropriate first step like we just had during our discussion? Please feel free to submit those via email, and we'll try to handle those. If you have an offer, would you like to be a stop on our field trip tour? Do you have other offers that you would like to make? We'd love to accept those as well. But I don't think we can do them with the lines open at this point. I want to get to our homework, and I think we do want to differentiate ourselves. I've been talking to people over the last few days trying to round up a speaker for the Wisdom Faith table that's coming up this Friday, which I'm also really excited about. Here's a people that there's a lot of different initiatives going on, a lot of collaborative learning sessions. This group is called an Action Network because we do try to foster an atmosphere where there will be action following our various learning sessions, and we'll be doing some follow-up to see kind of what happened with the actions. And the action that we'd like to ask you to do in the next month before the next AMS field trip is to look at your current state summary. So you're looking at a slide that should look like the document that Tina sent you, and you've been looking at the little area that's circled in yellow, and it talks about your program team. And what we suggest is you just pick up that current state summary, review that team section, and just make sure you kind of have the right people on the AMS bus on the team here. Is anyone missing, maybe based on the information that you heard today about the program at Swedish, while not everyone, either has the, information technology or some of the other aspects of Swedish, would there be other people you would add, any roles that you might have thought about, oh, wow, we need to get this or that person on the team? Think about how often you meet, again, given what you've heard maybe through this discussion, and if the goals that you've set for your team appear to be correct and you know what you're trying to accomplish and by when. And we'd like to ask you that by our next webinar, which is on the 22nd of February, that you will have looked through that and decided to refine or change at least one thing on your team, unless it's an absolute perfect team, in which case we'd love to hear about that as well. So that is the homework, and that's the action part about the Action Network, which I think in little pieces. Next up in the series, we're going to get on our really old bus, and we're going to go over the path, so we hope for good weather in February, to go to Yakima Valley Memorial Hospital to listen to their program. Different setting, different part of the state, different setups. I think it will be very, very interesting as the series goes forward. We'll certainly learn a lot. The team here at Qualis Health would really like to thank you for your attention. We had a remarkably good attendance at this. It's a fairly small group and had over 30 people on at the highest point, which is great. And I believe we even had a few from our team in Idaho, which is really awesome. So there's our contact information. Please do send offers or requests to Tina. You can send them to me if you want to. Tina needs to know about them, though, too. So thank you so much. Thank you so much to our presenter, Dr. Pock and John Zaris, also to our reactor panel, Drs. Mint and Lynch. We appreciate you very much. And we will be speaking to you again on the 22nd of February. Thank you so much.